My topic today is very interesting for me, of course, because I studied a lot on this area of medicine, and of course, it is a connection between biology, genetics, and medicine, and I think this cooperation will be very helpful for all of us. Okay. First of all, when we talk about allergy, because atopic dermatitis is type 1 hypersensitivity reaction disease, and of course, last few years we are talking about the pandemic of COVID-19, but really in our modern life and our modern world, we can say certainly about pandemic of allergy. So on this slide, you can see the prevalence of allergy in European Union, and we can say that 150 million European Union citizens suffer from chronic allergy disease. So it's 50% of population. So it's a huge amount of people. And very important that 50% will be affected in 2025, and we say also we know that 45% of allergy patients are likely to be misdiagnosed of allergy. So in real medical practice, it's very important because patients really don't know about the symptoms of allergy, and a lot of people really have allergy but don't know about it. So what are main diseases which are associated with IgE-mediated allergic reaction? And this is three main diseases: is atopic dermatitis or eczema, because there are some terms which we use in the United States or in Europe. So in Germany, usually we use atopic eczema term. In the United States and Ukraine, we use atopic dermatitis. So it's the same, and sometimes it's confused about to find some specific information out to understand what is different between eczema and atopic dermatitis. The second disease is bronchial asthma and allergic rhinitis. So these three diseases can coexist in one patient. And if you see to information in this slide, you can see how much money European Union spent for cover services for patients with allergic diseases. So it's 142 billion of euro can be paid every year to care of these patients. So, and very important also today, when we talk about special topics in atopic dermatitis about probiotics, but I also would like to talk about pathogenesis, pathophysiology of atopic dermatitis, and food allergy, because food allergy is closely associated with atopic dermatitis, and approximately 70% of patients with atopic dermatitis suffer from food allergy. So on this slide, you can see data from United States, and we see that we can see the growing of accidents of food allergy, especially for peanut allergy, for tree nut allergy, for meat and egg. So in Ukraine, it's more important to talk about milk allergy and egg allergy. So this kinds of allergy is we see more in patients. So, and of course, a lot of patients and physicians, scientists, biologists ask the question about why allergy is pandemic, why we have so many incidents of food allergy and anaphylaxis which can cause death of the patient. So, and the answer is very simple, because we, by using our modern life, we destroy communication between human and environment, between human and microbiota. And very important that just maybe 30 years ago, one very simple but very smart British pediatrician found that patients children from small families in United Kingdom has had more allergy in compared to big families. And also he found that people who lived in villages, countryside places in United Kingdom also had less allergen compared to big cities, to megapolises. And he wrote very simple articles about the epidemiology of this event, and the name of article is hay fever, hygiene, and household site. And after these articles, the new era of immunology and allergy began about study the hygiene hypothesis of allergy. And if you look to the slide, and all we know that infant after birth has some amount of immunoglobulins, IgG, especially from a mother, and we know that IgG can easily pass through placenta, and this immunoglobulins protects the child for next 4 months. And unfortunately, we know that this immunoglobulins will be destroyed in some times, approximately from 2 to 4 months, and a self-immune system of infant should start synthesis own immunoglobulins. And for this purpose, evolutionarily, our immune system in the first 4 months is very active for stimulating of B cells, and B cells start producing immunoglobulins. But very important, this child, we can see here on this slide, the first of all immune system has very active immune response type 2, and especially by activating T helper type 2, which release interleukin 4 and interleukin 5, and this cytokine stimulate B lymphocyte to produce immunoglobulins. And it's very important because immunoglobulins, we need immunoglobulins to protect from many invaders, from pathogenic microorganisms, but it's important first 2 years of life. So usually in normal condition, there is a switching from type 2 immune response to type 1, and it usually occurs in 2 years. So in 2 years, there is switching and immune system start transformed to be activated by T helper type 1, and it stimulates cellular part of immunity. So it's normal. It's a normal situation, and it's pretty enough to stimulate B cells to produce a lot of immunoglobulins, especially types G and A. But in case if infant grow in some, some modern conditions by using antibiotics, by using some chemicals and influence of pollutants from big cities, it's like the child grow up in sterile conditions. So immune system can't interact with viruses, can interact with bacteria. So, and this endotypes or phenotypes of immune system persist for more than 2 years. So it is very important. In this condition, when immune system is overactivated by T helper type 2, unfortunately, if there is a big amount of interleukin 4, B cells stop synthesis of immunoglobulins G and switch on to synthesis of IgE. So, and we know that IgE is a normal immune response, for example, against parasitic infection, Helminth's infection. But in this case, our immune system starts to react to some proteins, to some, for example, from pollen, from pets' dangers. So, and immune system wants to realize their potential by realize their poverty to synthesis immunoglobulins, but not immunoglobulins G, but IgE, and against to normal proteins particles. That is a problem. So, and this situation persists. So there is the deviation of immune answer. And of course, biodiversity is very important influence to our immune system development. And of course, the study shows that biodiversity loss may increase allergies and asthma. But you know, mothers and fathers don't understand this and keep their children in clean conditions, use chemicals, sanitizers to kill normal bacteria. So mother is allergic to biodiversity. So this is a big problem. And I see these problems in my patients. And when I explain to mothers and fathers why children have allergy and what is not good. And better not to tell her about the maggots, yes, because mother will use a lot of chemicals to destroy. So this, like this picture is good for child, especially the first 2 years of life, because it's really influence to normal immune system development. Another problems about allergy prevalence, high prevalence, is antibiotics use. So this is very big problem in modern medicine, and especially in Ukraine with free access for antibiotics. And for example, pregnant women can take antibiotics for any reason because they feel the high temperature and they should take antibiotics. The mother also, father prescribe, parents prescribed antibiotics for their children for especially first 2 years of life. But what we know about use antibiotics, we can see on this slide prenatal influence for pregnant women. We can see there will be increased incidence of atopic dermatitis, asthma, and hay fever. And if child is prescribed antibiotics, atopic dermatitis, asthma, hay fever, but it's not all. And unfortunately, we have data that also antibiotics influence to development of autoimmune diseases, because we know that autoimmune disease and allergic diseases hyperactivity, hypersensitivity of immune system, when immune system react to self protein, self antigen. And for adults, we know that if is over using of antibiotics can cause this severe disease like multiple sclerosis, so Crohn's diseases, or rheumatoid arthritis, or systemic lupus erythematosus. So the big problem is when we should talk about patients do not use antibiotics, and only physician should prescribe antibiotics, and never antibiotics should be prescribed by themselves, because it can cause serious problems in the future. Okay, so on this slide, we can see the protective lifestyles, the like farm dust or farm lifestyle. And we see example for especially for first 2 years of life. We know that especially we know about endotoxin, lipopolysaccharide from gram-negative bacteria that can activate regulatory dendritic cells, because in case of allergy, some proteins can cause stimulation of dendritic cells, which will transform to antigen presenting cells, and it will activate immune response type 2, and it will activate also innate lymphoid cells type 2, and it will cause the stimulation of B cells and to secrete immunoglobulins type E. But in case on normal natural conditions, the endotoxins, for especially stimulate toll-like receptor 4 and CD14 receptors on dendritic cells, and especially subtypes of dendritic cells, regulatory dendritic cells or tolerogenic dendritic cells, which will suppress immune response type 2, suppress T helper type 2. And of course, on this slide, we can see the benefits from fiber diet and gut microbiome, because usually bacteria release some important short-chain fatty acids, which can also stimulate tolerogenic dendritic cells and stop activation of immune response type 2. So on this slide, we can see 4 types of immune response, and I like this diagram because it shows us the problems with some diseases. So in type 1 immune response, usually its activation occur when macrophages release interleukin-12, and interleukin-12 stimulate T helper cells, for example, will transform naive T helper cells to T helper type 1, or stimulate innate lymphoid cells type 1, and it's released interferon gamma. And usually this type of response is important for intracellular infection, because the end results of this reaction will be production of huge amount of cytotoxic T lymphocyte will kill infected or mutated cells. On type 2 response, classical type 2 response is stimulation of B lymphocyte to secrete immunoglobulins G, or for example, in Helminth's infection, secretion of immunoglobulins IgE. On type 3 response, we have activation when we need activation of T helper 17 and T helper 22, and interleukin 17 and 22 play an important role to activate neutrophils and other cells and remove microorganisms from the cells. And also pathological events in case of hyperactivation of type 2, type 3 immune response is associated with autoimmune disease, for example, psoriasis or allergic contact dermatitis. And type 4 reaction usually is occur when immune answer is going to be close, and it stimulates transforming growth factor beta, which stimulate B lymphocyte to secrete soluble secretory form of IgA, and this IgA go to mucous membrane and protects from another invasion of pathogenic microorganism. And really secretory immunoglobulins play a very important role in the pathogenesis of many diseases. So, and on this part of the slide, you can see the healthy immune system when we see the same level of activation for type 1, type 2, type 3, and type 4 immune response. In autoimmune disease, we see hyperactivation of type 1 because it's stimulation of cytotoxic T lymphocyte overstimulation, and type 3, especially by synthesis interleukin 17 and 22. And in classical allergy or IgE-mediated reaction, we can see activation of type 2 immune response, but also decreased activity of type 1 and type 3 and type 4. So modern immunology and future immunology is about regulating of these 4 types of immune response. And I think genetics, biologists, molecular biologists, and physicians together try to understand this mechanism of regulation and to use this data to help our patients. So on this slide, we can see the prevalence of atopic dermatitis. Here is Ukraine, and we see that in Ukraine this is a huge problem because from 5 to 10% of population can be affected by atopic dermatitis. But if you see, for example, in the United Kingdom or New Zealand, the prevalence is more than 20%, so it's very high. And unfortunately, we have data that atopic dermatitis prevalence increase in Ukraine. So maybe next 10 years also will be more than 20%. Very important to remember that atopic dermatitis can coexist with asthma and allergic rhinitis, because this disease can be easily transformed from, for example, patient had atopic dermatitis, in next 2 years can be diagnosed by asthma or allergic rhinitis, or sometimes in severe cases we have both 3 diseases in one patient. So it's not easy to treat this patient. So very important, of course, environment factors. I talk about it, about pathogens, about interaction with microbes, about influence of chemicals, air pollution, smoking, and passive smoking is also influence for child, because we know the cigarette smoking pollutants can destroy epithelial cells or can destroy the first line of defense from many diseases. But if the first line of defense is destroyed, so inflammation can occur on this patient, and of course inflammation can deviate immune response. And very important is food allergen and diet, and what food we use for in real life, and because a lot of chemicals are in foods, and pesticides are used to, for example, to wheat production and etc. And of course, genetic predisposition. But genetic predisposition is a very tricky one because we know more than 200 genes which are responsible for allergy development. So, and we can't say that there are some important genes and another one is not so important. So, and it is complicated because a lot of information, and sometimes we can't really understand how to use the genetic materials, but I will show some examples at the end of the lecture how we use this genetics instrument to in real practice. And of course, altered microbiome, and because it's influence and regulate immune response. So on this slide, we can see the types of inflammation in skin in 3 main diseases. Today we're talking about atopic dermatitis, so we see the overactivation of T helper types 2, and also very interesting data that some children already have high level of innate lymphoid cells type 2. We know that innate lymphoid cells type 2 already ready to release interleukin 4 and 5 and 13. So without any sensitization can stimulate immune response type 2. And it's also, now we are talking a lot about these cells because high level is natural cells. They don't need any stimulation to participate in immune response. So, and also, we know about that this leads to activation of mast cell degranulation and eosinophils and effector cells of immune response. In contact dermatitis is type 4 hypersensitivity reaction when there is activation of Th1 cells, innate lymphoid cells type 1, and usually it occurs in adult patients. And cytotoxic T lymphocyte migrate to the site of contact with allergens and stimulate migration, after that stimulate migration of effector cells, which induce inflammation and cause hyperplasia of epidermis. And the third disease is psoriasis, when we have type 3 inflammation and activation of T helper 17 and 22. And it's very important that immune system react to antimicrobial peptides. We know that antimicrobial peptides is normal substances which are released by epithelial cells. So unfortunately, in some cases, our immune system can react to protector factors. So in case of psoriasis. Why I'm talking about these 3 diseases in this lecture? Because sometimes we have overlap syndrome when 3 diseases can coexist in one patient. So it's very important to understand that in real life, we don't see the classical patterns of inflammation. Sometimes we can see, for example, signs for psoriasis, sometimes for atopic dermatitis, and we really don't understand why patient with atopic dermatitis has morphological features of psoriasis. So it's very easy because now, unfortunately, we have more patients with both autoimmune disease and allergic diseases. So unfortunately, I think that modern life influenced to generate a new population of patients who coexist. So, and I told today about the 3 diseases coexist. And if you look to this slide, we can see the incidence and prevalence of this atopic dermatitis, food allergy, rhinitis, and asthma. And it's very important to know that atopic dermatitis begin in 2 months after birth. So it's very fast, and we see the high prevalence of atopic dermatitis is age is approximately 1 year of 1-year-old age, and slowly decrease during from 2 to 8 years. But also now for maybe 10 years, for last 10 years, we see more patients when asthma, allergic rhinitis started just together with atopic dermatitis, because 10, 15 years ago, we know, some trajectory for allergy development. So first was atopic dermatitis, first 2 years. After that, atopic dermatitis is classical, transformed to allergic rhinitis, and allergic rhinitis transformed to asthma. Today, we unfortunately see more and more patients when 3 diseases can start in one time and first year of life. So, and also atopic dermatitis influence to cause sleep disturbances, depressions, anxiety for the patients, can coexist with asthma. Allergic rhinitis also can be overlapping syndrome with contact dermatitis, psoriasis. And of course, if the skin is damaged, and of course, some secondary infection can be seen in this patient, and we'll talk later about it. And of course, some metabolic changes also influence, for example, obesity, and we know that adipocytes can secrete some pro-inflammatory cytokines and also can enhance inflammation in the atopic dermatitis. Smoking and cardiovascular diseases in adult patients, and especially atherosclerosis, also can enhance this inflammation. So sometimes we have very good genetic factors which predispose for atopic dermatitis development, but it's usually is related to 2 factors: is filaggrin and the collagen gene, and the mutation on these genes can cause some severe form of atopic dermatitis. But usually in majority of patients, we can find this mutation and can confirm that this mutation was the reason for atopic dermatitis development. And of course, it causes the defects in skin barrier and structure and function of innate and adaptive immunological response, and 25% environmental influence for air pollution, for example. So on this slide, we see the pathophysiology of atopic dermatitis and the interaction with microbiota of the skin. Because sometimes, when we talk about atopic dermatitis, a lot of articles is published about gut microbiota and atopic dermatitis. But now we know that there is one microbiome, and really skin microbiota and gut microbiota, it's whole organism. And in real life, we don't need to distinguish this type of microbiota, because it's like one change in one place can cause changes in another place. So we will talk about it. So in healthy skin, we can see the biodiversity of microbiota, because first of all, microorganism protects us from another bacteria, from another pathogenic microbes, because it's competition of food and nutrients. But here is 3 stages for atopic dermatitis. First stage is non-lesional skin. For example, it's maybe can be just beginning of atopic dermatitis. It's like first phase sensitization, or it can be, sometimes we can see this phase of inflammation in remission when patient has stable remission. So, but in this case, we can already see reduced microbial diversity, yes, and decreased microbial diversity will act on keratinocytes of epidermal layer of skin, and keratinocytes start release some cytokines, pro-inflammatory cytokines. We can see these main important cytokines is interleukin 25, interleukin 1 beta, TCLP, and interleukin 33. So these cytokines usually influence to dendritic cells on the one hand. On the other hand, it also can stimulate innate lymphoid cells. So can stimulate these innate lymphoid cells, and these cells already release some amounts of interleukin 4 and interleukin 5. So, and when amounts of cytokines is bigger than normal. So we don't know what is normal level of cytokines, but I think it's each organism has personal level, normal level of the cytokines, but some amounts bigger than normal, so I can say this in this manner, will stimulate B lymphocyte to release, to switch off the synthesis of IgG, and switch on the synthesis of IgE. So really, and when acute lesion occurs, when inflammation begin, we can see also that immunoglobulins IgE will attach to mast cells, and if it will contact with allergen, mast cell will degranulate and basophils and release, for example, histamines and other biological active substances which stimulate the migration of, for example, effector cells of immune response. It can be eosinophils, for example, and we know interleukin-5 stimulates the migration of eosinophils, and also neutrophils, unfortunately, also migrate to the site of inflammation, because neutrophils more dangerous than eosinophils because more destroying effects from proteolytic enzymes. And what we can see here, we can see that there is hyperplasia of keratinocytes of epidermal layer, because we know that the lifespan for keratinocyte is approximately 2 weeks, yes? And by influence of pro-inflammatory cytokines, usually these cytokines suppress apoptosis, so keratinocytes can die in normal manner. So, and this reason we can see the wide layer for epidermal layer. It's one problem. The second problem, we can see that reduced microbial diversity cause the gate to Staphylococcus aureus migration. And here we already see that Staphylococcus is here and start produce their substances. I will talk later about that, about this microorganism, and will enhance inflammation. So we have here, we have two problems. One problem is that immune system hyperactivity lead to stimulation of B cells to release IgE and subsequent factors. And on the other hand, we have Staphylococcus aureus, which also enhance this inflammation. But we know that acute inflammation is sometimes better than chronic inflammation, because chronic inflammation is immortal in many cases. And if we have chronic inflammation, it means that some level of pro-inflammatory cytokines persistently released, and it's like, and leads to immortal of these cells, and because the cells help to each other. So in case of atopic dermatitis, is chronic lesion in chronic phase of inflammation. Unfortunately, we also see the shift, the migration of immune response from type 2 to type 3. And we see the overactivation of T helper 17 and Th22. So it's not good, because these cytokines are very potent stimulators for neutrophil migration. And in case of this situation, when we have chronic phase of this immune inflammation, is also on this stage we can see overlapping syndrome with psoriasis, because this Th17 associated disease or allergic contact dermatitis. So this stage is very dangerous, and we still have problems with apoptosis of keratinocytes, and the term is lichenification, when we have very the wide of the layer is very wide, so it's problem, and because it doesn't work normally, and it's cause reduced microbial diversity and dysbiosis. So there are many terms which we use to describe the problems with microbiota, and some physicians very angry about some terms about what is dysbiosis, dysbacteriosis, bacterial overgrowth, and something like that, a lot of terms. But for me, it's not important because, of course, but you know, some physicians like this terminology, especially, they don't care about some, you know, pathogenesis, and they like, no, also they like some terminology issues about, talk about what is what is real, true, or what is not true, but we don't know what is true. And we can say that here we have disorders of microbiota. So we can say that there is reduced biodiversity of microbiota. So, and on this slide, we can see some problems. On the one side is normal skin, and on the other side is inflammatory skin disorder. So we see dysbiotic skin microbiome. So today we routinely use this method to detect microbiome in skin first. And of course, sometimes it can be overgrowth of some pathogens. And of course, this dysbiotic microbiome will cause skin inflammation. And this all events will lead to immune skewing and transformation of immune answer. And very important, when we have, so what is first? Yes, disorders in the skin or disorders in the gut. So can be both together, can be start together, because we know that some effector cells, for example, effectors T helper cells, can easily migrate to any side of the body. Yes, so for example, if some disorders occur in the skin, these specific types of cytotoxic T lymphocyte CD8 positive cells or dendritic cells, specific dendritic cells, or T helper cells can easily migrate, for example, to gut and cause problems in this place. So because can activate this inflammation. And it's very important to know that there is a balance between gut microbiota and skin microbiota, and this communication is very important. And now I see a lot of articles about studying communication between disorders of skin microbiota and gut microbiota. So it's very important to understand this. Okay, so next, what we know about atopic dermatitis and microbes. And on this slide, we can see non-affected areas of healthy skin. We can see that we have a lot of microbes, actinobacteria, corynebacteria, Rhodia, actinomyces. And what we know about in atopic dermatitis. So we know that there is decreased relative abundance of these microbes. And in some cases, for example, some Staphylococcus, different types from Staphylococcus aureus, decrease relative abundance of these types of microorganisms and increased abundance of Staphylococcus aureus, for example, that is pathogenic in case of atopic dermatitis. So on this slide is, I like this slide because it describes the influence and action of Staphylococcus aureus on the pathogenesis of atopic dermatitis. And it's very important to know that when dysbiosis occurs in the patients, why it occurs? It depends from many factors. It can be, so patient use some chemicals or food influence, or some creams, or etc. So many factors can go, and even genetics. So, and first of all, we know that Staphylococcus aureus cause formation of biofilm, and biofilm release a lot of factors which destroy the structure of epidermis. First of all, on this slide, we can see that biofilm stimulate keratinocytes. So keratinocyte will release pro-inflammatory cytokines, especially thymic stromal lymphopoietin is very important factor, because we have drugs which block this factor, and it's pretty effective in case of patients with atopic dermatitis. Also, we know that biofilm release some phenol-soluble modulins, which also stimulate releasing of pro-inflammatory cytokines, and these pro-inflammatory cytokines, especially interleukin-1 and interleukin-36, stimulate T helper cells type 2, and also, unfortunately, stimulate gamma delta T lymphocytes, intraepithelial cells, which can recruit neutrophils by stimulation of keratinocyte to release interleukin-17. So neutrophils very bad in any cases of chronic inflammatory diseases. We know about that delta toxin of biofilm can directly stimulate mast cell, and mast cell will degranulate. And we know about super antigen, which activate also basophil and mast cells. And we know that biofilm also can directly stimulate Langerhans cells and dendritic cells of skin, which also stimulate releasing of type 2 cytokines, interleukin-4, 5, 13s, and also stimulate J2 cells. And very important is that this biofilm also releases one interesting substance is aryl lysine, which decrease synthesis of antimicrobial peptides. So antimicrobial peptides play very, very important role to protect epithelial barriers from pathogenic bacteria. So, and Staphylococcus suppress synthesis and releasing of antimicrobial peptides. So it's very important. And in normal situation, commensal coagulase negative staphylococci, here we can see on these slides, release some factors which suppress, should suppress, if there is a big amount of this kind of staphylococci, they can suppress Staphylococcus aureus. And it's important by releasing antibiotics, which are now actively studied in case of atopic dermatitis. So, and also skin microbiota by releasing a special form of tryptophan, D-tryptophan, release some active metabolism of tryptophans, which activate some factors which decrease the synthesis of thymic stromal lymphopoietin. So, because it can, you know, that this metabolism suppress, activate G proteins coupled receptors, and inhibit histone deacetylases, and it's suppress inflammation. You can see on this slide, so suppress the gene transcription for TCLP and leads to decrease the level of this factor. So it is important that skin microbiota by releasing, so metabolism of tryptophans can cause very positive effects and decrease type 2 inflammations and improve skin barriers. So, and of course, I need to talk about the effects of, about some substances of Staphylococcus aureus and how it's influenced to severity of atopic dermatitis. So I talk about some toxins, and alpha toxins also can directly form pores in keratinocytes and cause disturbances of epidermal barrier integrity. Yes, because we know that keratinocytes joined with each other by tight junction. So it's a junction which help communicate with the two cells, but alpha toxin can destroy this junction. So it opens the gate. And for example, allergen can easily pass to subepidermal layer, or can some microbes also pass to this gate, because it's very important, and tight junctions play a very, very important role in many diseases, and especially in atopic dermatitis. And also proteases, which facilitate dissolution of stratus corneum, the layer of epidermis, and Staphylococcus superantigen, directly trigger B cells expansion and cytokine release. And it can cause also, it's very important to remember that it can cause non-specific antigen-presenting cell-mediated T cell activation, so can activate T cell without antigen-presenting cells, so it's very fast activation. And of course, it will enhance inflammation, chronic inflammation. Protein A triggers inflammatory response from keratinocytes through activation the tumor necrosis factor receptor 1. So we know that this factor also is very potent pro-inflammatory cytokines. And also phenol-soluble modulins. Also, we know that can be released by staphylococci, and it stimulates dermal mast cells and induce skin inflammation. So we have a lot of factors, negative factors from this bacteria, which cause harmful effects on skin in patients with atopic dermatitis. So next, this slide is interesting because it explains the gut microbiota and the very famous some syndromes when we talk about leaky gut. So it's a lot of articles about these syndromes, but it's also a problem with connection and tight junction between epithelial cells. So in case of, we have disorders of microbiota, we have disorders of junction between cells, and it causes invasion of pathogenic bacteria. And we also know, unfortunately, when we have this kind of disturbances, we have decreased synthesis of IgA. So IgA, secretory form of IgA, play very, very important role. So it's maybe main important factors that protects from many pathogenic microorganisms. So, and if there is a leak gut, we can see there will be activation of macrophages, will be activation of dendritic cells, will be stimulation of type immune response too. And we know also remember that this is not events that happen in gut, but it's by systemic circulation. These cells can easily migrate and go to the site for skin and to site where there is disorders of epithelial layer of the atopic skin. So, and on this slide is also pretty interesting because it shows us some fluctuation and some shift about some other dermatological diseases. So here is normal situation when we have enough amounts of microbiota. We call it normal microorganisms, but we know that some microorganism in some situation can harm of can cause some disease. So it depends from many factors. So but they coexist with us and they help us and we help them. So we help to each other. But we can see what really happened in atopic dermatitis when we see the dominance of single microbes. So it's very important in compared to psoriasis when we have a lot of microorganisms which can persist in case of this disease. So microbiome and microbial components, DNA, lipoteolic acid, LPS, pathogen-associated molecular patterns, and bacterial metabolism, especially short change fat acids, indole 3 aldehyde, indole 3 propionic acids. They have two mechanisms. One mechanism is non-immune effects, integrity, epithelial barrier, mucus production, because they play an important role, and mucus also is protecting factors, and positive effects on permeability. On the other hand, immune effects is stimulate anti-inflammatory cytokine release by stimulating regulatory dendritic cells, tolerogenic dendritic cells, and also inhibition type 2 immune response, especially by inhibition T helper type 2, and increase synthesis and secretion of IgA. So IgA is also very important. So we can see a lot of disease which can be associated with disorders of microbiota, and probiotics can influence to synthesis of nutrients. They have direct antagonism for pH modulations, regulate gut motility, inhibition of bacterial adherence, and also very important role hypocholesterolemia actions. And we know a lot of study about influence to atherosclerosis development and anti-allergic activity. So a lot of effects, and we can see a lot of disease and cancer, allergy, osteoporosis, bacterial vaginosis, liver disease. So, and probiotics really play an important role on this case. So in conclusion, I can say for the action of probiotics on this simple slide, we can see that probiotics can stimulate dendritic cells, tolerogenic special types of dendritic cells, and dendritic cells will introduce interleukin-10, which will stimulate to transformation of naive T cells to regulatory T cells, and the decreased activity of T helper types cells. And two cytokines, interleukin-10 and tumor growth, transforming growth factor beta, suppress the allergic inflammation and play a very important role. So we know that probiotics stimulate production of the cells. So in this slide, you can also see the effects I already told about it, about short chain fatty acid and influence, because they suppress anti-inflammatory effects. They suppress NF-kappa beta. They suppress synthesis of pro-inflammatory cytokines and stimulate synthesis of interleukin-10 and transformer factor beta. And also is influence to the regulation about tryptophan metabolites, stimulate also anti-inflammatory effects, improve skin barrier, and act on the balance between Th1 and Th2, and pathogen-associated molecular patterns from microbiota also stimulate pathogen receptors, associated receptors, for example, toll-like receptors, which influence to normal immune response. And we remember that also food allergy and microbiota, because sometimes we can see, for example, in patient activation of B cells which produce specific IgE to food proteins, and after that the atopic dermatitis will develop very fast. So on this slide we can see what bacteria are studied and what are help to modulate immune response. Usually it's bifidobacterium, lactobacillus rhamnosus, and a lot of drugs especially contain this type of bacteria. And what we can see is that it's usually stimulate the or regulate the immune response to make balance between Th1, Th2. Also, we know about stimulation of tolerogenic dendritic cells and suppression of IgE production. On this slide, we can see some clinical trials, and I would like to say that a lot of trials now are going, and sometimes we have good results, sometimes we don't have good results. For example, here we can see in children and with high risk of allergy and their mothers, and 57 patients took probiotics and 55 placebo group, and we see the result of the study that probiotic groups decrease incidence. So we can say that probiotics use can decrease incidence of atopic dermatitis and can be used for treatment of atopic dermatitis. So we also see the positive effect of probiotic group, but some studies don't show positive effects. I will talk later about this. And in adults also we have that probiotics groups also decrease symptoms of atopic dermatitis, decrease level of IgE, and decrease level of TCLP and tumor necrosis factor alpha. So, and unfortunately I don't have much time, but I will show very shortly my study about efficacy of probiotics in atopic dermatitis and the influence of polymorphism CD14 receptors. So we know that endotoxin interact with two receptors, CD14 and toll-like receptor 4. It is important to co-receptors is work on big receptors and stimulate intercellular activation of MyD88 and IREX activation. So, and we know that some genotypes of the genetic polymorphism can influence to allergy. Why? Because this gene is located in promoter part of the gene, and it's very close to gene which is called IgE. And we know a lot of studies that genotypes, single nucleotide polymorphism of cytosine is this patient have high level of IgE, and this group of population has increased risk for asthma development, allergic rhinitis. So we divided patient to 6 group about the level of IgE and genotype. CC, as I said, is usually people have high level of IgE, and we see the effects of probiotics on the patients, and we treat patient with 2 bacteria, 3 bacteria probiotics, Lactobacillus, Bifidobacterius, and BB12. And this study was pilot 28 days, and we see, so we can use some indexes to see the efficacy of treatments. It's like severity indexes or points. We calculate points, and if the index is high, so the severity is high. So in this case, for example, we can see this patient before treatment, the index was 12, and on day 28, this was 3. So this patient used combination therapy, topical corticosteroids plus probiotics therapy, and another groups use standard therapy without probiotics, and TT genotypes is not usually associated with atopic dermatitis, standard therapy and probiotics. And we see the better results in patient, unfortunately don't have time, in patient with CC genotypes. So in CC genotypes, we can see better effects of probiotics in compared to other genotypes. So sometimes we can use data from single nucleotide polymorphism and to see effects, but we need more clinical trials to understand the efficacy of the drugs. And it's very important to understand that each organism is individual organism. So we don't really know all effects on the concrete patient. So how to prevent from allergy? Very important, some important information. Of course, disinfection, this factor will cause allergy. Single child will cause more children, the better biodiversity of your family. Cesarean section cause more allergy. Junk foods, baby foods, more allergy. Yes, and what prevent? Farming lifestyle prevent from allergy. We have very good studies from American studies from Amish and Amish populations. More pets, especially 3-4 dogs, protects from allergy. Large family, homemade foods, fibers, breast milk, probiotics, so no allergy. And so this is house where you should live. This is family you should have. This is pets which protects, because very interesting study shows that 4 pets protect from allergy. Not 1 pet, 4 pets. And the study shows that the family who has 4 pets, they don't have allergies. So it's very interesting study. This child behaviors, and of course drink, use probiotics, healthy milk. And of course, when I said personalized medicine, what we are just started, and of course we should understand all mechanisms. And of course, the human brain can manipulate this data, can calculate this information. And now we have a lot of articles about mathematics models and about cluster analysis, which help us to understand. For example, today will be a lecture, Professor Boyko Nadia from Uzhgorod. She will talk about the personalized medicine and how to check the microbiota in concrete person and understand how to make personalized medicine for concrete patients. So I think because disease is heterogeneity is very huge in atopic dermatitis. So we can say in real practice, we can say we have 45 subtypes of disease. And of course, we can't use general principles of treatment for each patient with common groups. So I know that future for next generation of medicine, but unfortunately, a lot of data, and unfortunately, we still can't use this data in real life, but sometimes, but we know progress on these areas. Thank you.
Thank you very much for your very interesting and detailed report. And have you any question? Or maybe I begin. I want to ask you, please, as I understand from your report, there is information about Staphylococcus that it is the first factor, initial factor in atopic dermatitis. Yes, or other disbalance in microbiota of skin microbiota is also.
Okay, thank you for interesting question. So it's very important question because what is first? Yes, egg or
yes.
That is always asked. So of course, the first step is dry skin. Yes, so in infant dry skin, and unfortunately, dry skin cause transepidermal water loss, and it also cause decrease of pH in this. So this is maybe it's not atopic dermatitis, but we see it first. So after that, or maybe before that, maybe it's already disorders in microbiota. Why? Microbiota in gut, and because if there is disorders in gut microbiota, this automatically will cause disorders in skin microbiota. So, and why is it occur? Because maybe pregnant mother took antibiotics, for example, or maybe ate some food, not healthy food. It's very difficult now to say what is healthy food because we really don't have healthy food because it's unreal in our life now. And this factor cause also influence to child, to infant, and infant in 1 month has dry skin, and maybe already disorders. I think it's already, there is a disorders in microbiota, and it's caused, and if we have reduced abundance of biodiversity in the skin of, and we can see that factors even in healthy people with dry skin, we already see reduced abundance of microorganisms. So in this case, Staphylococcus aureus is like to find this condition because decreased pH and decreased biodiversity, so no competitions, and the life is competition, you know, and this and especially this microorganism play important role in case of atopic dermatitis. So, and of course, each organism would like to survive, and Staphylococcus start release a lot of cytokines, and unfortunately, this cytokine is same or similar to the mechanisms which occur in IgE-mediated reaction. So these two reactions. So in this case, this microorganism enhance inflammation, and so in this case, of course, we should use probiotics to recover this microbiota, and we use because if we recover microbiota in the gut, we automatically will recover microbiota in the skin. So it's very interesting, but it's work.
Okay. And please, we have some more questions from our participated, but in the chat. If you, I read you. You mentioned that the atopic dermatitis can coexist with 2 other dangerous diseases as well. Do you possess an information how big is the percentage of people who have all 3 illnesses?
Okay, thank you. Mhm. Thank you. Yes, it's big problem because unfortunately we don't have data in Ukraine, but what I see in my patient is approximately 20% of allergic patient have these three diseases. So asthma, allergic rhinitis, and atopic dermatitis. And I didn't show a slide about microbiota disorders in in asthma and allergic rhinitis, but there are a lot of studies with learn about the influence of microbiota disorders in development of asthma and allergic rhinitis. So even I think that allergy is growing up, and in Ukraine we will have more prevalence because modern life, Western modern life in our country is just started 30 years ago, maybe 25 years ago, in compared to United States when this kind of life is more than 60 or 70 years. So, and the second problem is that also we see patients with allergic diseases and autoimmune diseases. So it's more dangerous than just the allergic diseases. So approximately 20%.
Okay, thank you very much. And one more question. It is believed that vitamin D affects on the condition of atopic dermatitis. What do you think about this?
Thank you. Very interesting question, because I didn't mention about vitamin D because I have slide with the influence of vitamin D on the allergic diseases, and because my time was I didn't catch my time. So, and yes, vitamin D, there are a lot of studies, a lot of clinical trials about influence of vitamin D to pregnant women and about increased or decreased prevalence of atopic disease. We have a lot of studies. So, and we know that if mother takes vitamin D, it can decrease the possibility of atopic disease development. Also, we have data that vitamin D supplementation helps to decrease symptoms of atopic dermatitis, allergic rhinitis, and asthma. But, you know, some meta-analysis show positive effects, some don't show positive effects. So, and the problem is that what we can see in real practice that, for example, patients go to laboratory, check the level of vitamin D and prescribe vitamin D. And you know that if there is high amounts of vitamin D, it can be dangerous. If we remember biochemistry, and we know what happens if will be high level of vitamin D, so it can cause severe diseases and liver diseases, so it can be very harmful. So, and I think the problem is that it should be used for certain group of patients, and that I say because some trials also don't show efficacy of probiotics, but some trials show good efficacy. And I think it's because it's a huge diversity, heterogeneity of diseases, and we use personalized approach to detect this patient and prescribe the treatment.
And one more question. And what about hormones in the treatment of atopic dermatitis?
So we use topical steroids to treat atopic dermatitis. So there are a lot of topical steroids. So these drugs are safe because it's not systemic steroids like prednisolone or methylprednisolone when severe patient takes these pills, and it can cause Cushing syndrome. And topical corticosteroids is safe, and systemic effects is like probability is very low is when patient overuse these drugs. So usually patient we prescribe these drugs, ointment or cream 2 times per day, and for 2 weeks, for example. And when patient go to remission, patient don't use topical corticosteroid. But very interesting, now we have a lot of new cream which contain probiotics, and this group is, yes, probiotics, emollients and plus probiotics. So, and a lot of clinical trials are going. So I think so will be combination, systemic probiotics, pills orally, and local probiotics by cream.
Okay, thank you very much for your interesting report and for the practice advices from you or to prevent atopic dermatitis. And thank you very much.
Thank you for inviting me. Have a good day. Bye-bye. Thank you.